Greetings, hello, and welcome to Addressing the COVID-19 Crisis, our weekly open forum webinar series for pharmacists. I'm Michael Hogue, President of the American Pharmacists Association and Dean of Loma Linda University School of Pharmacy. If this is your first time with us, we welcome you. For those of you who are returning faithful followers of this webinar week after week, we welcome you as well. This week, we're going to do something that I think is kind of monumental. We're going to reflect on what has been about 6 months of the COVID pandemic and really the shutdown here in the U.S. and talk about where we started from and reflect on that and where we are now. Our profession has seen some tremendous advancements, and the science around COVID has matured. And so I think it's good for us to pause and maybe take a look back and see where we were and look forward to where we're headed as well in some regards. So we're excited about that. Now, we're going to use APHA's internal experts to help us with this today. We are very happy to have with us our team of staff professionals. Dr. Dan Zlot will be joining us initially to share where we have been with epidemiology and with drug therapies and where we are today and what we know today. So I know that'll be a great update for you. We're also joined by Dr. Lisa Bernstein, who is the Senior Vice President for Pharmacy Practice and Government Affairs at APHA, and a long career with the FDA prior to joining APHA. And we're going to talk about how the profession has advanced over the course of the pandemic, and again, talk about the future just a little bit as well. We'll be joined by Mitch Rothholtz, APHA's Chief of Governance and State Affiliates, and he's going to share with us a little bit about pharmacist well-being during the COVID pandemic. That's an important topic we need to think about. We'll also be joined throughout the presentation for Q&A today by Ann Burns, Vice President for Professional Affairs at APHA, as well as Michael Baxter, Senior Director for Regulatory Policy at APHA. Now, as we do every week, we will be taking your questions. It won't just be simply me talking with our guest today, but we really want to hear from you. This is an opportunity for you to be able to share your experiences and ask your questions. On the GoToWebinar control panel, there is a questions box, and we would just encourage you that either right now or as questions come to your mind, that you take the time to type those questions into the question panel. I monitor those as we go through the webinar. At the appropriate time, we will unmute your line and you will be able to then ask your question verbally of any of our panelists. We'll take any questions about any subject related to COVID-19 during today's webinar. We may take questions throughout the entire webinar today, folks, depending on the number of questions that we get in and the types of questions that we get asked. So please just, we encourage you to go ahead and ask your questions when you have them. If you have not done so already and you have joined us by cell phone or landline, you need to enter in your audio PIN on GoToWebinar so that we have the ability to unmute your line. If you don't put that audio PIN into your phone, then we can't unmute your line and we can't let you ask your question. Now, if you have no audio or you just prefer not to speak to the audience, you can put no audio in your question and I will ask your question for you. We'll get to as many questions as we possibly can. You'll also notice in the GoToWebinar control panel that there is a handouts tab. The handouts and slides for today's program are available to you for download. All of the links in the slides are active and will take you to active websites, so it'll be very functional for you. And as always, we are recording today's webinar. It will be posted at pharmacists.com in the COVID-19 resources section. So with that, we're going to just go ahead and jump in and get started with our exciting discussion of where we've been and where we're headed. Let's start by asking Dr. Zlot. Dan Zlot, would you please join me on webcam, and let's talk a little bit about epidemiologies and drugs. Dan, isn't it just amazing and hard to believe almost that we're, what, 6-7 months into this pandemic? I mean, can you believe it?
it's almost surreal how fast and how slow at the same time has gone over the course of the epidemic. So, as I look at the first case being diagnosed in late January 20th of 2020 till now, and you look at the epidemiology curves, and we'll get into some of that in a little bit, it's really been kind of fascinating to reflect on the ups and downs and the different aspects of our response to COVID-19 and how that's impacted things. So,
yeah, well, speaking of epidemiology, I think you created a few slides for us. I'd like to have you walk through for our audience to just show where we've been with this disease and where we are now.
Yeah, absolutely. So, as I mentioned, we are the first case of COVID-19 in the US was diagnosed January 20th, 2020. And this slide is taken from the Johns Hopkins epidemiology site. They've got the best collection of epidemiological data on COVID-19 out there right now. And this slide shows cumulative cases of COVID-19 since the outbreak of the pandemic. And so you'll notice that for the first little bit, really up until late March, there really wasn't a huge uptick in the curve. It's not to say there weren't a lot of cases, but when you have a scale that we have now on the millions of cases, there just wasn't a significant number of cases. And then right around late March, early April, you start to see that curve pick up, and it's relatively flat all the way until June, late June, early July. And then you see the slope of the curve pick up a little bit more. And there's a lot of debate as to why that may be. Some people think that that's because of the loosening of some of the restrictions at that time frame, and that caused more cases, more spread. Other people say that that's because of increased testing, and so we're finding more. The truth is probably a little bit of both was affecting that. So if we can move on to the next slide. And this is the cumulative deaths. And there's an interesting pattern here where with the first slide, we saw sort of an increase in the slope. Here we see a decrease in the slope of the initial slope. And this is my interpretation of this. So this is very much anecdotal. So don't take this as fact. But when I look at how steep that the death curve was in the April-May timeframe, and then it seemed to flatten out a little bit in between May and July. And I think that's really where the healthcare team was figuring out how to deal with COVID-19. When I look back at my time as a researcher, when we got into unknown territory, we were figuring things out, and it took us some time to figure out how to address certain toxicities that we see. But once we had our game plan down and we could apply those principles, we often saw a decrease in the severity of toxicities. So I think something similar may be going on between the May and July timeframe. And then, of course, you see that the death rate pick up a little bit from July up until present day. And I think that correlates as well to the increased frequency or the increased incidence of COVID-19 cases. So that's the cumulative death summary. If we can move on to the next slide. Now, the cumulative incidence of COVID-19 and the cumulative death rates don't tell the whole story. As you know, we have fairly aggressive testing in the US. There are some countries who have probably done better, some countries who have done worse. And so we may know we have more data than some countries, but it's important to put that in the context of how many cases per unit of population, in this case 100,000 people. And again, you can sort of see that the curves there very much mimic the overall case curves for both the epidemiology, both the confirmed cases. And if you go to the next slide, that is the same thing for the deaths. The curves are very similar, so that's not a surprise. It just helps to kind of put it in perspective again, so you can see the per population incidence of COVID-19. And then the thing that we're really focused on, if you move on to the next slide, is daily new cases. And so this is the thing that we really obviously want to see coming down. And as you can see, in that June-July timeframe, we had a significant uptick in new cases. Again, a lot of people think that that's due to the loosening of restrictions. Others make claims that that was due to testing. Again, I think there's an element of both in there. But really, since the first, second week of July, we've seen the number of cases on average across the United States come down pretty significantly. So hopefully that trend continues.
And I think that one of the things that pharmacists have heard bannered about in terms of understanding where we are with this is percent positive, as percent of cases positive, as a metric of just where we are today. And I think I saw some data just this week that said that the national rate of percent positive tests is about 6% overall. And maybe I'm misquoting there, but I think that's what it said. I know here in San Bernardino County, Southern California, our percent positive test rate is still at about 13%. So we're much higher than that. Tell us about that. Is that a metric that pharmacists ought to pay attention to locally in terms of what's going on in their own community?
That's a fantastic question, Michael, and absolutely. And I was just going to say that data in particular is really best viewed at the local level. Johns Hopkins, again, has the best source of this data that I've found, and they've got it broken down state by state and even county by county. And that percent positivity, what Michael's referring to, is what percentage of people tested are coming up positive with COVID-19. So that gives you some rough idea of the prevalence of COVID-19 in your community. And obviously, the higher the percentage is, the more people in the community have it, which tends to indicate higher spread. So when we talk, there's been a lot of talk about high risk or red zones, green zones, and what is that based off of? And to your point, Michael, that's really based off of that percent positivity. How many people in a community are testing positive for COVID-19? So absolutely, you should be keyed into that. If you're in a community where you have a high percent positivity, be aware that there's a lot of activity in the community. Take extra precautions as you're thinking about interacting with patients, protect your staff, et cetera.
Yeah, okay, that's great information. Well, let's talk about drug therapies. There have been a lot of drugs out there that have been tried and tested, and there's a lot that are still being studied. But I want to start with remdesivir because I think really, as proven, tested positive results go, remdesivir's probably had the strongest results. So tell us about remdesivir.
Absolutely. So remdesivir was, as you said, Michael, the first therapy that we had that had proven efficacy in randomized controlled trials. And so this was a summary of that study. It was the ACT-1 trial, multi-center trial led by the NIH, the National Institutes of Allergy and Infectious Disease. And so they enrolled a lot of people, and then actually in their interim analysis, they found positive results. If we can move on to the next slide. So in this is the summary. So really what remdesivir showed is an improved time to recovery. So people who got remdesivir tended to recover more quickly than those who did not. And so that's the big takeaway. Interestingly, remdesivir did not have a statistically significant impact on mortality. It had a trend towards improved mortality, but it didn't reach statistical significance. And I failed to mention, remdesivir is an antiviral therapy. So the way that remdesivir works is it inhibits viral replication. And so there's a lot of ongoing research about when's the best time to give remdesivir, who benefits the most, is it less ill patients or more ill patients, and the exact dosing schedule, because remdesivir is hard to come by. There's not enough of it to go around. All of those things are still sort of ongoing and open questions.
Yeah, and I know that pharmacists encountered access issues with remdesivir early on, especially our hospital pharmacists. There was a process in place, as I recall, when the drug was very first approved or recognized. The hospitals had to go through a process to get allocations of remdesivir. Is that still happening, or is remdesivir more widely available to hospitals now?
I believe access has increased. However, I believe most hospitals are still on allocation.
Okay.
So there's more available than there was, but there's just a limit to how quickly they can manufacture it without totally converting all the plants over to manufacture remdesivir.
Now let's talk about another drug. I know I had a close friend who was hospitalized with COVID-19, and he received dexamethasone. It seemed to make a big difference in his care. Tell me about dexamethasone.
Absolutely. So many of you are probably aware of this, but for those of you who are joining us for the first time or haven't been following this as closely, it turns out that one of the major causes of morbidity and mortality with COVID-19 is not actually the viral infection itself, it's our body's immune reaction to the virus. That really potent immune reaction is what causes a lot of the lung damage and other tissue damage that results in the severe respiratory and cardiac symptoms associated with COVID-19. So with that in mind, it makes sense that a potent anti-inflammatory may be beneficial, and there were a number of different anti-inflammatory approaches studied, one of which was dexamethasone, and that turned out to be the one that had the best evidence for it. So this data comes from the recovery trial, which is a randomized controlled open label trial in a pretty good number of patients, and they gave patients either IV or PO dexamethasone, 6 milligrams a day. So decent dose, not a super high dose, but still a fair amount of steroid. And if we can move on to the next slide. The outcome here was an improvement in mortality. And so this was the first drug that really showed a benefit in terms of decreasing mortality. And there's some interesting aspects here in terms of patient selection. So patients who required either oxygen supplementation and or mechanical ventilation benefited the most from dexamethasone therapy. And in fact, if we move on to the next slide, this is a visual representation of the same data. In patients who did not require oxygen support, that's panel B for those of you looking at that, you can see that the mortality curve for dexamethasone is actually a little bit higher than the usual care arm. And so there's an important aspect to patient selection to make sure that the right patient gets the right drug, which of course is what pharmacists are all about. Definitely, there are some patient populations who do not benefit from dexamethasone. However, if you happen to be in the category, if you have patients who are in the category of requiring oxygen therapy or who are requiring mechanical ventilation, there's a statistically significant decrease in mortality when they're given dexamethasone. So that was our first big win in the mortality front with COVID-19.
Well, that's great. I mean, it is really great when you're in the middle of a battle to have some wins, and I'm glad we had a win there. I just mentioned that we did get a text in our question box from a pharmacist from Santa Clara, California, who confirmed that, in fact, her hospital and others are still on allocation for remdesivir. So our assumptions there, it seems, are correct based upon our listeners' feedback, and we appreciate receiving that feedback. Now, in the last week, probably the therapy that's gotten the most news is convalescent plasma, which I would also mention that my good friend who was hospitalized and received dexamethasone also received convalescent plasma under investigation. And so tell us about what's happened in the last week, really, and kind of the history behind it as well.
Absolutely. So convalescent plasma is something that has been investigated for COVID-19 pretty much from the very, very beginning of the outbreak. The idea of convalescent plasma is not a new idea. Believe it or not, it was used as early as the early 1900s in the Spanish flu outbreak in 1917, 1918. People were using convalescent plasma as a treatment for the Spanish flu way back then. So the attractiveness of this is that it's probably one of the most rapid therapies you can deliver because it relies on our body's ability to learn new antigens, new pathogens, and develop an immune response against them. So you take someone who's recovered from COVID-19, hopefully they have high levels of antibody against COVID-19, and you give that plasma to someone else, and that someone else gets the antibodies against COVID-19. So that's the general idea there. And recently, you probably all saw that the FDA issued an emergency use authorization for convalescent plasma for the treatment of COVID-19. And as best we can determine, this was based on the data that I'm going to talk about here. So this was the expanded access program for convalescent plasma. So it's basically a way for people to get access to an experimental therapy. So essentially what it is a multi-center, open label, non-randomized, uncontrolled trial. It does have a very large number of patients, about 35,000 patients from 2,800 centers, and patients got convalescent plasma donated by recently recovered COVID-19 patients. It's important to know that antibody levels in the plasma units were unknown at the time of transfusion, and the intervention that was being studied, and I use the term loosely because, again, this is an expanded access program, not necessarily a study. Basically, anybody who got a transfusion of at least 1 unit of convalescent plasma was included in the study. If we can move on to the next slide. So here are the results. Patients who were transfused with convalescent plasma within 3 days of diagnosis did better than those who received their transfusion later. And that was statistically significant. You can see an 8.7% mortality rate at 7 days versus 11.9%. And that difference maintained its statistical significance when they followed those patients out to 30 days of follow-up. And again, the statistics are there for you. The p-values show that that was a highly statistically significant outcome. And interestingly, after the fact, they went back and analyzed the immunoglobulin levels in the plasma units that the patients received, and there was a pretty good correlation between the concentration of anti-COVID-19 IgG and outcomes. So if you received a unit of plasma with high IgG levels, you had a lower mortality rate than if you received a medium a unit of plasma with medium levels of IgG against COVID-19, and that was even better than if you got the low levels of IgG. And again, that was statistically significant, and that dose-response relationship again was seen all the way out through 30 days. There's a couple of issues with this study. It's important to point this out so that everybody understands. This was obviously a non-controlled trial, so this is essentially anecdotal data, just a huge quantity of anecdotal data because there was no comparator. And also, Michael, just as your friend, in your friend's experience, people were allowed to receive other therapies along with the convalescent plasma. So it's not really, it's difficult to tease the effect of all of that out. And because there were almost 2,800 centers involved in this, it will probably be years before they can go back and analyze, A, just obtain that much data, and B, analyze it and make sense of it all. So take it with a grain of salt.
That's right. Well, you know, it is a very hopeful thing that we are beginning to advance in our understanding of this disease, and that we do have at least now what appears to be 3 therapies, convalescent plasma, dexamethasone, and remdesivir, as options for the management of COVID-19. Now, in the interest of time, we're not going to cover the 4th therapy that has perhaps been the hottest topic in the treatment of COVID-19, but for our listeners' viewing pleasure, we have slides that you can read later that contain some information about hydroxychloroquine. And it's been, Dan, I think just in summary, hydroxychloroquine has perhaps been the therapy that we had the most excitement about, and then have perhaps had some of the greatest disappointment with, and then have had the greatest controversy with as well. Would you say that's accurate?
Absolutely. Early on, there was some anecdotal data that was very promising with hydroxychloroquine, and keep in mind we had nothing else available. So everybody was looking at that very heavily. As the data evolved, there was a lot more mixed data, and none of that was controlled. So there was some positive and some negative. And then when we got into the more later phases, we now have randomized controlled data that doesn't show great efficacy. And then there's been some additional data that's come out again in various studies, some showing some positive results and some showing some negative results. So it's very much a mixed picture. And as you said, unfortunately, has also become highly politicized rather than just us looking at data and being able to make decisions based on that. And so that's really also muddied the waters quite a bit, made it difficult for all of us to decide how to approach hydroxychloroquine.
All right, well, Dan, thanks for giving us an update on the therapies and on epidemiology. Now I'm going to ask Elisa Bernstein to join us because we've got some then and now things to talk about relative to pharmacists' scope of practice changes and advocacy and patient care services. Lots of coverage of things. Elisa, thanks for sharing your insights. I know that the APHA staff, as well as the staff at all the other pharmacy associations and governance and advocacy, have really been running hard the last 6 months because there have been so many changes, right?
Yeah, it's been incredible. You know, I started at APHA in October, and things were really busy then. And once COVID hit, it really took off. And what I saw as a difference is all the collaboration and all the work that pharmacy has banded together during this unprecedented time to get some new authorities and move pharmacy forward.
Yeah, that's great. Well, let's start out with testing, because I think that's probably the most prominent thing we're all aware of, is that there's been a lot of changes with pharmacists being involved in testing. So tell us about that.
Yes, a lot has changed, and it continues to change and evolve. Back when it first started, even before COVID, the authority for pharmacists to test was very limited in states. And there weren't a lot of testing sites for COVID when it first started appearing, and those were mostly retail chains that were setting up testing sites in parking lots. There were limited tests available. Very few were approved, let alone that you could rely on, and variable coverage of payment for the tests. Now, since then, we had the FDA and CMS clarify that pharmacies are patient care settings for CLIA-waived tests, so we can do these tests. And in fact, in May, the Office of the Assistant Secretary for Health issued an authorization or allowing pharmacists to order and administer tests in all states, preempting state law for COVID, flu, and RSV. Now, this is only limited to the public health emergency. And the problem, though, also continues is that there is no clear billing pathway for services, so pharmacists are still struggling on how to implement it. Now, there was a win earlier this week in your state, Michael, in California, where the state finally removed a barrier that was in place for pharmacists to be lab directors so that more pharmacies can actually do the testing. So that was a great win by the California Pharmacists Association and their efforts there.
I think, Elisa, we'd be remiss if we did not, however, with this, it's exciting on the one hand that we've gotten this expanded authority, but I think for our listeners, we need to acknowledge the fact that as pharmacists have these expanded scopes, we recognize and understand that many pharmacists, especially in the community sector, are employed by large corporate organizations. And I know that it has been stressful for many of our pharmacists who have had to try to implement this on top of additional responsibilities that they may have had, and perhaps not with any increase in staffing. So I do want to acknowledge for our pharmacist listeners today that APHA understands that advocating for these practice changes is important for the advancement of our profession, but APHA is also working very closely with chains to discuss the need for us to, for the chains to have better support of with staffing, appropriate staffing, so that as you take on these roles in your community pharmacies, that you can actually do them in a way that meets the patient's needs and your needs. Let's talk a little bit about immunizations, because that's the other hot topic. I think we're even more interested in that today as we near flu season, but talk about immunizations.
Yeah, well, so there's a couple of things going on in immunization. As you know, there's a lot of work in investigating immunizations for COVID, and we've been working hard through APHA and with our coalition to get greater authority for pharmacists to administer, order and administer and get paid for it. In the meantime, at the same time, there has been a significant decrease in the amount of childhood vaccinations because parents are reluctant to go to the doctor's offices, and some of them aren't even open. And so in an effort to increase the childhood vaccination across the country, I think it was last week, some of these weeks are a blur to me, HHS, maybe it was 2 weeks ago, but HHS gave pharmacists and pharmacy interns the authority to order and administer the ACIP, the Advisory Committee for Immunization. Actually, Mitch helped me.
Immunization practices, right.
Thank you. The vaccines that are recommended for children ages 3 to 18. And so again, what they did was the HHS gave pharmacists this authority, and also its authority in all states, but there are certain requirements that it's specific vaccinations, the pharmacist has to have specific training, they have to have basic training in cardiopulmonary resuscitation, and there's some other things involved as well. But there's been pushback, and we've heard this from the pediatrician community and the medical community, that questioning why pharmacists are the ones to fill in this gap when they're open for business. And so we're working to clarify that pharmacists in many states have already had this ability to do that, to give these vaccines. Right. We haven't had any guidance yet regarding the COVID-19 vaccine, but we have heard from HHS that they are working on something, and we should hear something soon.
Well, it's great. And a couple of things that I want to add again for our listeners about pediatric immunizations and about the topics that you've discussed. For our listeners, you'll note that both of these items are limited to the public health emergency period. As you hear about all the changes going on in pharmacy, I would ask our listeners to type into the chat box, are there parts of this that you think ought to be made permanent after the pandemic is over? Why don't you share your thoughts with us in the question box, and I'll give a report on what we're hearing from pharmacists who are on the call today in terms of the things that they'd like to see be made permanent after this is over in terms of a pandemic. I also want to just mention to you that APHA has been pretty surprised, I would say appalled might be a better word, at the degree that some of the medical associations have made this about turf, when in fact this needs to be about patients. We need to see that everything we're doing during this pandemic serves the patient and what's best for the patient. And this does not need to be about turf. And so I really hope that my colleagues in medicine with the professional associations will reconsider the way they're coming across to consumers, because if what we do serves the patient well, then it serves everybody well, and that's really important. Now let's talk about compounding. There have even been some issues with compounding that have advanced during this time.
Yeah, FDA has traditionally had very, very little flexibility for 503A compounding pharmacies. So these are the pharmacies that compound pursuant to a patient-specific prescription. Very limited enforcement discretion. This is what I used to do at FDA. I know how very narrow FDA was in providing flexibility. Now, because of the needs out there in the community for different therapeutics and drug shortages, FDA has provided broader use of enforcement discretion. And what that means is when that if a pharmacist is compounding, or a pharmacy is compounding beyond what is typically allowed, FDA won't take action if the compounding is within the confines of what if FDA is allowing. So, for example, FDA is allowing the compounding in certain medications for hospitalized patients without a patient-specific prescription, because there has been such a shortage of certain therapeutics that are used specifically in hospitalized patients. FDA has also said that they're not going to enforce a 5% rule in which that would limit the amount of prescriptions that cross interstate. And so whether or not these are all this is a theme, this little blue bubble is a theme on all the slides. This is limited to the public health emergency period. So we'll have to see, again, maybe we'll talk about this later, about what might be continued after the public health emergency.
And a hot topic for all of us is telehealth. We've seen changes with the telehealth requirements. Can you tell us what's advanced there?
Yeah, very limited opportunities before. There were some for MTM. Now, the CMS has identified certain flexibilities for outpatient services, for evaluation and management via telehealth using real-time audio and video. Again, this is in an incident-to relationship. with a physician. And we just heard recently that that CMS has clarified that pharmacies that are accredited and enrolled in Medicare can deliver DSMT, diabetes self-management training services via telehealth. And up until very recently, CMS was absolutely silent, and we had asked them again and again and again, and finally they did provide that clarification.
Well, I just give a little bit of feedback from our audience. One of our pharmacist listeners, Monica Olitsky, said that after the pandemic, it would be nice to see the continuation of testing, whether it be for flu or COVID-19 in the pharmacy. And also, pharmacists should still maintain the ability to immunize children 3 to 18 because of the accessibility issues. And I think, Monica, we would agree with you on that, accessibility and patient convenience is really, really most important. So we would agree with you on that. Now, we are running a little bit short on time, Elisa, but let me just ask you quickly, there have been some other regulatory and practice level collaborations. Could you quickly just get us through those items as well? Because there's some important stuff here.
Yeah, on the slide that's showing, I'm just going to really say that it's been a tremendous, we've seen tremendous outreach from the regulatory agencies in working with pharmacy and responding to our questions and requests for meetings. And they're really recognizing the value that pharmacists provide and are providing during this pandemic. On the next slide is basically really there were several issues early on in the public health emergency that we were spending a lot of time on related to ensuring pharmacist safety, and then operational issues that were really becoming barriers to providing patient care. And now we're seeing a lot of these problems. They're still existing in terms of the PPE and distancing and having some shortages, but we're finding that there are workarounds and solutions that many people are trying to figure out, and but there's still a lot more work to be done there. I think that's my last.
One other thing is I just have to say I'm really proud of our professional associations in pharmacy for how we've stuck together as a profession. And, you know, I know that we have some of those collaborators that are on the call with us today, and I just want to speak very directly to our sister pharmacy organizations to say how proud I am of our entire profession. Never in my career history have I ever seen our pharmacy associations working more closely together. And my hat's off to you, because all of you have been doing such a great job at collaborating. And I can just tell you, as a pharmacist and a member of many organizations, and I can tell you on behalf of other pharmacists throughout the country, we want you guys to work together more closely when this is over, and not just make this about the pandemic. So I'm giving applause to the staff of all of the pharmacy associations for the great work, and I think it's illustrated in these statements that Elisa has put on this slide, showing this kind of collaboration.
And Michael, the next slide really is a reminder, so a shout out to all of our colleagues in the states and NASPA who have, you know, really done monumental, huge efforts in getting orders, the governors issuing orders and getting the waivers done, and really actually implementing a lot of these measures in the states. And we again, they're partners right with us as well.
Yeah. Well, let me ask our listeners to go ahead and type your questions in. If you have questions for any of our panelists, we're going to take those questions. I do want to give Mitch Rotholtz an opportunity to tell us about APHA's WellBeing initiative. I don't know about any of you, but during the COVID pandemic, my sleep cycle's been off just a little bit. I don't know if anybody else has had an odd sleep cycle, but Mitch, why don't you join us on camera? And Elisa, thanks for being on with us, and tell us just a little bit about the APHA Wellbeing Initiative.
Thank you, Michael. I'll be brief on my comments, but as you all are aware that we have a well-being index to help pharmacists measure their level of distress and well-being. And we also have created some resources for you as you go through the tool and identifies areas where you have increased distress, ways that you can manage those. As reports have come out from across the whole healthcare system, every healthcare provider in the system is stressed. And so we're all focusing on trying to help the individuals manage through this time of stress and distress. And so the next slide, please. When you take the well-being index, it actually gives you the measures and shows you areas that you should pay a little more attention to. And then it also has a link to resources that have been created by APHA, as well as resources that are available from Mayo, who's our partner in this well-being index. Next slide. We have approaching 10,000 individuals who have completed the evaluation. And the uniqueness of this tool is that it's not a one-time evaluation. It's an ongoing. You could take it multiple times to see where are your sensitive points, or where you're more distressed than other points. And then you could go and look at the videos, look at the tools to help you manage through that. And so I want to remind you, if you haven't signed up, on the slide is the sign up for the Wellbeing Index. Or if you haven't taken your evaluation lately, go in there and take it to see how you're doing as an individual. We're also sharing this information with our state affiliates so that they too can see how the distress level is in their state and how they can help pharmacists at the state level manage distress. Back to you, Michael.
Thanks, Mitch. I appreciate that. And it's time for our audience to interact now. We're going to put a polling question up about your well-being. I'd like to hear from all of you. Since the beginning of the COVID-19 pandemic, my personal well-being has significantly improved, remained about the same, worsened, or significantly worsened. Tell us about what your personal situation is. We'll just get a pulse of those who are on the call today in terms of what your personal well-being is. Just click right there on the screen. That's all you have to do, and we'll be able to see your responses. And all right, we're getting some good ones. Just again, all you have to do is just click the siren beside your response on the screen, and we'll try to get the results out to everybody here pretty quickly. All right. Okay, let's see what the results are. Well, it looks like about a third of you have remained the same, and about a third of you have worsened. But nearly a third of you say that your life, your personal well-being has improved. So it looks like we've got a pretty split group in terms of personal well-being. And so again, for those of you who have seen your well-being worsen, please take advantage of the resources Mitch has shared with you. I think you'll find that it's very helpful. Now, I want to take questions from our audience, and just in a few minutes, we've gotten a couple questions in that I'm going to have to ask because of no audio for our participant. Dan, could you tell us how long immunity lasts in someone who has COVID? This question comes up pretty frequently about the duration of immunity following COVID infection. What do we know?
That's a great question, and one that the answer is ongoing. As far as we know, immunity, some of the earliest cases now were 6-7 months ago. We know that immunity lasts that long, and that's all the experience that we have. But so far, almost 100% of people who are exposed to COVID-19 develop an immune response, and even low levels of symptoms or no symptoms seem to be enough to produce a significant immune response. And that response is maintained in the best studies looking at low complication or no symptom COVID-19 infections, at least 90 days. So that's as far as we know. And for people who actually had COVID-19, again, 6-7 months, that's our experience. So far it looks like the response is lasting.
Yeah, and I'll just use another analogy. You know, we use the best knowledge we have about the current virus, but we also use our past knowledge about other infectious disease causes. And we know that with H1N1, for example, H1N1 was, you know, relatively new in 2009 when it popped onto the scene because we hadn't seen it in recent years, but the reality was that there was an H1N1 strain of flu that had circulated back in the 1950s and 1960s, and it turns out that when people in 2009 got sick with H1N1, it was actually younger patients that had more of a problem with H1N1 and were sicker and were more likely to be hospitalized. Older patients who were alive when H1N1 had circulated back in the 50s and 60s actually did not get as sick. Turns out that they had some residual immune memory, and it seems to have protected them. So we learned a lot about even flu virus during that. Now, this is not a flu virus, obviously, and coronaviruses may behave very differently, but our past history with the way viruses work in our immune system tells us that we're optimistic that there'll be some longer term immunity, I think. Would that be fair?
Absolutely. It would be very unusual for us not to develop some type of a long-term immune response against this type of virus.
Yeah, that's great. All right, Dan, thanks for that. We appreciate that insight. Mitch Rotholtz, I think that you have maybe something to share about an additional immunization change that we might not have covered during the immunization section. Do you want to share that comment with us, please?
Well, one of the things that we've been dealing with since COVID is how to reinstate or enhance the provision of routine vaccinations during COVID. And so just reminding the audience that this is like following the bouncing ball, that the CDC guidance is related to the provision of pharmacy services under COVID, as well as vaccination during COVID, were things that we worked through since early in the year with CDC and others in order to give the providers a comfort level of reinstating their immunization programs in their practices. So again, we encourage folks to look at those guidances and put in place how they can get their vaccine programs optimized to meet the needs of the public as we get ready for a COVID vaccine to come to market. And so we're entering into the flu season. It's now important to encourage your patients to, when it's appropriate, to get their flu vaccination. And then the other thing that we learned from last week's webinar that talked about the COVID clinical trials is you might want to go ahead and add to your screening questions of patients, are you in a COVID clinical trial for vaccine? Because there may be some waiting times that may be there, but it also gives you a sense of where the person is thinking in terms of protecting themselves as well.
Yeah, and one of the things I want to highlight for our listeners that Mitch has mentioned is last week we had a great session on vaccine safety and COVID clinical trials. And if you haven't taken time to listen to that session, let me really encourage you to do so, because it was phenomenal. It was a fantastic session learning about what's going on right now with the vaccine clinical trials. And there's a lot happening, and pharmacists can be actively involved in recruiting patients and even participating in those clinical trials. In those clinical trials. So we would just encourage you to take a listen to that. Now, one of our listeners today, Rashid Abdo, has asked, what is happening with expanded roles of pharmacy technicians? So, Elisa, I wonder if you could talk to us about what you've observed in collaboration with our state partners and others relative to pharmacy technicians and their roles, and is there anything underway related to that we need to be aware of?
Hi, yeah. In the states, each state has been going through and ensuring that there is appropriate authorities for technicians to help. That's where some of these staffing issues have come up, that because of of the disease and people being out, there is even a greater reliance and need for technicians. When the HHS came out with the statement last week about immunization, it covered pharmacists and pharmacy interns. It did not cover technicians. And so that's an area to further explore.
Okay, all right, that's great. Well, and again, we know our state partners are working hard on technician-related issues, and we would encourage our pharmacists who are on the program to listen, to work carefully with your state pharmacy association partners and to talk with them about those state plans. Now, we've got one last clinical question that I want to take, and then we'll move into a few announcements. We've received a question about Oleandrin, and Dan, I wonder if you could help me with this one. Oleandrin has been touted as a potential cure for COVID-19. Can you tell us what the available evidence says about Oleandrin?
Sure. Oleandrin is something you may have heard about in the news. I think the inventor of MyPillow, if I remember correctly, has been touting this. So Oleandrin is an extract. It's a natural product, and to date, there's no clinical evidence that it has any efficacy. There's a paper on BioRxiv, which is the equivalent of MedRxiv. It's preprint, hasn't been peer-reviewed, that shows that in vitro Oleandrin is able to inhibit viral replication. That is interesting and probably warrants further study, but that's nothing new. There are a lot of compounds out there that have shown the ability to inhibit viral replication in vitro in the Petri dish that have not panned out. So I wouldn't get too excited about that yet. And if your patients are asking you questions, let them know that it's being tested in Petri dishes and it hasn't been studied in animal models or people. So we've got a ways to go yet before we can make any judgment one way or the other about Oleandrin.
All right, well, thank you for that answer as well. One other piece of clarification regarding pharmacy technicians, the HHS amendment that authorized pharmacists and intern pharmacists under the supervision of a pharmacist to prescribe and administer vaccines, regardless of what state laws may or may not allow pharmacists to do in those states for pediatric patients, really has no impact on pharmacy technician laws that might already be in place in the states. So if your state allows pharmacy technicians to administer vaccines, nothing changed with that. Let's just be clear about that with the pharmacy technicians. Now, I want to move into just a couple of updates for everybody to make sure that we are all on the same page of what's going on and what's coming in the next week or so. First of all, let's talk about some resources that are available, practice resources. I always like to remind all of us that during times of pandemics, there are those who would seek to make a buck in a nefarious way. And that includes sometimes people who think that they have the latest and greatest thing and they want to try to take advantage of you from testing standpoint and others. And so we would just encourage you to look carefully at the fraudulent schemes that are out there, and APHA has provided a highlight resource at pharmacists.com that will help you to be able to discern between what's real in the market and what's fake, and help you, in fact, make good decisions that keeps you and your patients safe. I also want to just point out that that testing resource is probably one of our most frequently used resources in our practice resource page. You can click right on the handout link, right on this active link. It'll take you to the resource, or you can go to pharmacists.com to pick that up. In addition, we would just like to make you aware that APHA members receive approximately every 2 weeks an update on legislative and regulatory activities directly from APHA. You can check your email inbox for APHA members to be able to get that update. And there was an update for the last couple weeks and activities that are going on that came out yesterday. So if you didn't see that in your inbox or you're an APHA member, please do check your spam folder and make sure that you've whitelisted the APHA email address to be able to get your legislative and regulatory update to know what's going on in practice. And I also want to come back to something we ask you to do just about every week, and that is to take action with Congress. Now, just 2 days ago, we got some information from CMS that was actually quite discouraging related to payment for pharmacist services. The agency just doesn't think they have the authority to grant pharmacist payment for our clinical care services during COVID or any other time. And so it's even more important that we get Congress to act. And that means we need you as the constituents of members of Congress to demand and expect that these Congress people include pharmacists as a part of the HEALS Act or in other legislation that allows us to test and to immunize both during the pandemic and beyond. And so we just urge you to take action. You can do that at the pharmacist.com Take Action Center that APHA provides, and you can do letters there. You can also find the number for your member of Congress and call and actually ask them verbally. And I also would encourage you that many of them are at home in their districts right now because of this time of the year. And so reach out to them and ask them in your own district to in fact support this patient access to pharmacist provided patient care services. I also will point out that we have several 15-minute CE, 15 to 20-minute CEs available. I love these because I'm in a hurry and I don't have a lot of time to be able to sit down and look at a CE or listen to a CE, but these little snippets about things that are very relevant to COVID-19 in our everyday practice are very informative and helpful. And so I just encourage you to take time to listen to these. There are quite a lot of these. I don't know what the exact number is, but we've got quite a number of these up and really available to you to earn CE. Also, remember for APHA members, there is the APHA Engage platform. Some great discussion there this week among pharmacists who are sharing information about how COVID-19 is affecting their practice and the things that are going on in their practice, and asking questions and getting feedback from each other. So the information exchange has been very good. Now, next week, we are going to take a break because we'll be coming up on the Labor Day holiday weekend. And just like we did for the 4th of July holiday weekend, we decided that some of you need a vacation and it's time to take a few days off, even if it's a staycation, and hopefully you'll do that and have a chance to relax. So we'll do no weekly webinar next week. However, I'm excited to tell you that the following week on Thursday, September the 10th, we're going to offer continuing education for our weekly webinar, something we've only done one other time during the pandemic. Our topic will be fall, flu, and pharmacy amidst the COVID-19 era, and our guest speakers are going to be people that you will not want to miss. And in fact, for those of you who are in the immunization world, you'll know our speakers very well. But I'm going to leave that in the bag and not release their names to you because I want you to pay attention and look for the registration link that's coming. So it'll be all about immunizing against flu in the fall, given that we're in the pandemic. And so again, great opportunity for you to earn 1 hour of CE. Thank you so much for joining us today for our weekly webinar series. Thank you for all that you do each and every day to take care of the patients in your local community. You are making a difference in people's lives. Have a great weekend. God bless.